Hi, this is Dr. Kevin Kirby. I'm going to be talking again today about root theory and a little bit about tissue stress theory. In the second part, we're going to be talking about the inaccuracies in root biomechanics theory that I had noted early on in my Biomechanics Fellowship and continuing on to my early practice career. You have to understand that I had been, as a biomechanics fellow, at the California College of Podiatric Medicine in San Francisco. I was tasked with teaching the third and fourth year students podiatric biomechanics measurements, gait examination, casting for orthotics, orthotic adjustments, and making orthotics. And we were taught on root theory. There wasn't such a thing as tissue stress theory back in 1984 to 1985 when I was the biomechanics fellow at CCPM. So as a result, I began to see patients on my own and began to take note of many problems that I started to see with the root theory that had been taught as dogma at the California College, without any suggestion there could be any deviations away from this root theory, as that there are other possibilities of the way the foot could work. So in 1990, 27 years ago, in some of the first newsletters I had done with Precision Intricast, I had a list of 9 inaccuracies in the root theory dogma that was taught to me that I wanted to describe and discuss in detail. And that's the topic of what we're going to be discussing in this video, about the inaccuracies that I felt back in 1990 and during my Biomechanics Fellowship in 1984 to 1985 in root theory, and to why I think that these are critical problems with roots ideas that were taught, and also makes it difficult for us to accept these root ideas as being fact. The first inaccuracy that I had noticed was that the teaching was that the calcaneus of the foot during relaxed calcaneal stance position had to be in vertical position in order to function normally. One of the biggest problems we see with this idea is that there was a large range of inaccuracy in drawing heel bisections, not only among students. Students could be plus minus 5 degrees away from each other, and clinicians, even the biomechanics professors who were teaching us, could easily be 3 to 4 degrees away from each other. So it was very difficult for any two people to agree of how to bisect a calcaneus, and so it made it difficult to accept the fact that this calcaneal bisection was truly an indicator of how the foot should function. Obviously, many of us became fairly close to each other, but it was accepted if we saw a calcaneus that was not vertical but rather stood inverted or everted. We accepted that as, and was taught that as, having something wrong with it or not normal. And this was this to me bothered me because I saw already the inaccuracies and inconsistencies from one biomechanics professor to another in drawing heel bisections, whereas a patient may have a vertical calcaneus when one biomechanics professor drew their calcaneal bisection on their foot and stood on it, whereas in another professor that may have drawn the bisection on 3 to 4 degrees inverted from the other professor would be seen to have a 3 to 4 degree inverted calcaneus. And this, to me, bothered me, that it was somewhat a haphazard way of assessing gait function, foot function, and how foot orthosis should be balanced. And remember, as I discussed in the last video, orthotics were balanced routinely with heel vertical without any allowance to have the orthotic balance with heel inverted, unless the patient became maximally pronated, was maximally pronated at the heel inverted position. The second inaccuracy, which we've already discussed, is that it was widely believed that the calcaneus has only one true bisection, and this is something that I had actually openly challenged Merton Root with at one of his seminars, telling him that I thought that these calcaneal bisections were highly variable from one individual to another, and he, during the question and answer, ridiculed me for saying that that even a monkey could draw a correct heel bisection, and that he thought that the professors at the California College were not teaching this correctly, that this is a very easy thing to do and anyone can be taught how to correctly bisect a calcaneus. This was approximately in 1985 or 1986 when I attended one of the Root seminars, and Merton Root was very angry that I would suggest that the calcaneal bisection could not be drawn on, and that from one calcaneus to another, from one practitioner to another, there would be any variability if they were doing it right. So this is another problem I had with the Root theory, that he very strongly believed that each calcaneus has only one true bisection, whereas I had seen quite a variability not only in the students but also in the biomechanics professors, who were supposed to be at that time the most knowledgeable people in the nation on how to draw a calcaneal bisection. One of the other pieces of information that we were taught was that if the calcaneus was to evert past 2 degrees everted, then the subtalar joint would become maximally pronated. It was somewhat the idea that the calcaneus was the hub of the foot, and that once it tilted a little bit too far, it's going to continue tilting. Well, this has numerous problems with it. One of them, it ignores what's happening in the forefoot. It ignores the stiffness of the mid-tarsal and midfoot joint complex, but this was widely believed and taught at the California College of Podiatric Medicine in the early 80s, and it makes no sense, especially when we consider that the heel bisection was so variable from one clinician to another and from one student and practitioner to another, that one practitioner's heel vertical position could be a heel everted position of 3 degrees, meaning the same foot should have been staying vertical, whereas the other foot should have been pronating to maximum pronated. So to me, this was another red herring, and something that I couldn't reconcile with the known laws of physics at the time. The fourth inaccuracy was that we had this idea, and it was taught at the time at the California College, that a foot orthosis made from a cast held in the subtalar joint neutral position. So in other words, if we had a cast, took a negative cast of a foot for an orthosis with the subtalar joint neutral position, that somehow this orthotic would hold the foot in the subtalar joint neutral position during not only in stance and gait. And this is something that I actually talked to John Weed about during my 3rd year, saying that the subtalar neutral position, if we're balancing it vertically, so if we were to take an orthotic made around a subtalar neutral position cast of a patient that was maximally pronated, and they were, let's say, 6 or 7 degrees everted in relaxed calcaneal stance position, and we made him in subtalar joint neutral position and balanced it vertically, I could see how that would tend to correct some of the excessive eversion of the foot. However, I told him I couldn't see how, if we had someone who was maximally pronated and made an orthotic around heel vertical, which would be maximally pronated for them, how that could somehow force the foot into neutral position. And he actually told me at the time that that was a good observation, and he didn't have, I thought, a good explanation for it at the time. So this was widely believed that the foot orthosis made in the neutral position would, in the subtalar neutral position, would somehow position the foot in the subtalar neutral position. This made no sense to me, and it was obviously not the fact, but something that was widely believed and widely taught. One of the other inaccuracies that I had a problem with was that the standard examination of the foot that we did. That would include hip range of motion, malleolar torsion, ankle joint dorsiflexion, first ray range of motion, forefoot to rearfoot relationship, subtalar joint range of motion, subtalar joint neutral position, and the static examination of the patient standing, neutral calcaneal stance position, and also gait examination. So these measurements that we were taught to the students, and that also I was teaching to the students as a biomechanics fellow. As I mentioned in the last video, I was seeing that regardless of if I had performed these measurements as well as I could on a patient, that many times, even though these numbers came out that the left and right feet were fairly symmetrical, many times we would see obvious differences in the foot shape and also the foot pathology that occurred. So I was starting to become convinced well toward the middle and latter part of my biomechanics fellowship that even though I was becoming quote-unquote an expert in the root examination method, I was not seeing that this root examination method, all these measurements we took, were doing me any good to predict gait function or to predict pathology. And this also discouraged me, and I felt that that it was not the case that these biomechanical measurements were actually doing us much good in predicting pathology or in predicting the gait examination of the patient. One of the other inaccuracies that we that I in the biomechanics theories taught by Root was that this idea that the forefoot to rearfoot relationship of the foot is congenital. It was believed that the forefoot to rearfoot, whether it's a forefoot varus deformity or forefoot valgus deformity, was something we inherited, and that it could be changed over time if we have excessive pronation of the foot, which we call a forefoot supinatus, where the forefoot inverted on the rear foot over time and was a positional deformity. But in my view was that we saw patients who tended to have forefoot deformities and whether they're inverted or everted deformity. So inverted deformity of the forefoot would be a forefoot varus deformity, and an everted deformity of the forefoot would be a forefoot valgus deformity, that these tended to change with time. And I also saw that we could actually manipulate the foot. If we had a patient with a forefoot varus, which we didn't know if it was a supinatus or a structural varus, that we could manipulate the foot for 2 or 3 minutes and change the forefoot to rear foot within a few minutes. So to me, this meant more that I felt that the forefoot to rear foot relationship is largely dependent on the forces acting across the foot over time due to the viscoelastic nature of the ligaments that hold the bones of the rear foot, midfoot, and forefoot together, and that it may be partly congenital, but it really is a dynamic relationship that does change over time, and probably not only changes in the direction of having a supinatus, but having a valgus deformity, depending on if the foot's becoming more inverted, the rear foot's becoming more inverted with more supination moment being placed on it, or more everted at the rear foot with more pronation moments occurring. One of the other things that bothered me a lot also during my biomechanics fellowship, and also as a biomechanics student in my podiatry school days from 1979 to 1983, as a podiatric student at the California College of Podiatric Medicine, is that the standard orthotic that was made was always ended at the metatarsal necks. In other words, it was rare to see a foot orthosis made with a forefoot extension with a top cover, and even more rare to see any sort of a reverse Morton's extension or a Morton's extension or an accommodation for a painful metatarsal or a varus wedge or valgus wedge. This Root believed that the orthotic didn't need to have a forefoot extension, since he felt that the orthotic by itself ending to the metatarsal necks would produce enough quote-unquote functional control to alleviate the compensation for the deformities that he measured in his biomechanical examination. Luckily, at the time, we had Dr. Harry Levac and Steven Subotnick in the Bay Area making sports orthotics. And when we saw these patients in our clinic, we got to see orthotics that were made with forefoot extensions, which made a lot of sense to me, since I felt that this should have no problem for the patient, and actually the patients seemed to benefit from this. So this was another problem we had with the root ideas at the time, that the orthotic somehow had to be made of a rigid thermoplastic, had end of the metatarsal necks, couldn't have a forefoot extension, and was actually discouraged to have a forefoot extension. So this is something where obviously now forefoot extensions are widely used and accepted, but in the early 80s and in the California College of Podiatric Medicine, this was not encouraged or even allowed in some instances, even though the forefoot extension would have obviously given the patients more relief of their symptoms and made them function better. One of the other things we saw was that the idea was that if we had a calcaneus that was inverted in a relaxed calcaneal stance position, that this was going to be causing a foot to be abnormal. In other words, again, we go back to the idea that this vertical calcaneus is a normal foot, the non-vertical calcaneus is an abnormal foot. So if we were in the clinic and one of the clinicians saw a calcaneus that was inverted, we thought, oh, they must have a rigid forefoot valgus causing a supinate. They must be maximally pronated at their inverted position. It couldn't just be a foot that was more inverted at the rear foot, with some with some extra pronation range of motion allowed at that time. The idea was that and this is something that was taught by John Weed, was that the calcaneus would evert to vertical and then stop there due to some dynamic characteristic that was not explained to us why it would stop at vertical. One of the pictures in the root books was that the medial and lateral calcaneal tubercles, here we have some pictures from Root's normal abnormal book. We can see in the subtalar neutral position, he has diagrammed that the medial tubercle and lateral tubercles are resting on the ground when the subtalar joint is neutral. That tends to indicate to me that, well, maybe there's some intrinsic plantar calcaneus shape that will keep this subtalar joint neutral. Well, this is not the case. In the radiographic study I did with Alan Loendorf and Renee Gregoria, who are podiatry students during my Biomechanics Fellowship, we found that indeed in the subtalar neutral position, in this case, the medial tubercle was always weight bearing, and that the lateral tubercle was resting off the ground, by a 21-degree angle. So these ideas from Root's book up top here, that there's a plantar calcaneus shape between the lateral medial tubercles, where there's some inherent stability of the plantar calcaneus being created, that this is false. This is just another podiatric myth that was, I think, was created possibly by the illustrations done in both the compendium done by Tom Scarlato and also by Root, Weed, and Orien's books, that tended to think that this heel vertical position was somehow stable. This has many problems with it, as I've mentioned before: inaccuracies in heel bisection, differences between even podiatric biomechanics professors in drawing heel bisection. So this whole idea that this heel bisection determine function or determine normalcy, quote unquote, of the foot, to me was becoming untenable by the time I got to the end of my Biomechanics Fellowship in June of 1985. And also, one of the last ones I want to talk about today is this idea that a foot with a everted forefoot to rear foot relationship should be always treated with the heel being balanced vertical. What we had in the root theory was this idea that we were treating deformities. we weren't treating pathologies. We didn't make we were taught not to make the orthotics differently if they had plantar fasciitis, if they had posterior tibial tendonitis, if they had perineal tendonitis, if they had sinus tarsus syndrome, if they had patellofemoral syndrome, medial tibial stress syndrome, iliotibial band syndrome, Achilles tendonitis. We basically, in the root theory, were taught, and what I taught is you treat it to the foot deformity. In other words, if you measured a 3 degrees of forefoot varus and in a relaxed canal stance position, the foot pronated to 4 degrees everted, you would do a heel vertical orthotic. You wouldn't put in any sort of extra correction for it necessarily. You wouldn't invert the orthotic. The medial heel skive had not been created at that time, so that wasn't available or even thought of at the time. So this we were treating to deformity rather than the case of, let's say we had a forefoot valgus of 6 degrees that we measured, and we had a foot that was suffering from, let's say, a runner who had medial tibial stress syndrome. We would just balance the heel vertical without really taking into account the stress acting on the tissues that are causing the pathology and how we can optimize orthotic treatment to maybe invert the orthotic more, maybe add a forefoot varus extension to the orthotic. This was not done back in the early 80s at the California College of Podiatric Medicine under the guidelines of root theory. So we can see, though, that even though the proponents and the advocates today of root theory are moving the chain, as we say, they say, well, this was done, this was not done. The root theory was very restrictive. It didn't allow you to add forefoot extensions. It wanted you to think that if the foot wasn't heel vertical, it wasn't a normal foot, and all these inaccuracies I've gone through were bothering me quite a bit at the time. And and then with my experimentation with the subtalar axis location that occurred during my biomechanics fellowship, I actually saw a light at the end of the tunnel as far as finding a way to try to better treat my patients who had pathologies of the foot and lower extremity due to abnormal forces, both internal and external forces acting on the foot, and also design my orthotics more effectively by using the knowledge that I could design the orthotic to reduce the stress on the tissues that are causing the pathology, so the patient can be pain-free, function better, and do their activities, whether sports activities or daily activities, with less pain, and eventually heal them. Thank you very much, and we're going to be continuing this video presentation on tissue stress theory and root theory in the coming videos. Thank you.